I will try and keep it as Indian as possible. So basically, we deal with very diversified anatomies when we are dealing with coronaries. And every anatomy or every coronary requires a personalized approach. A general approach cannot be done. So first I'll speak about a stent which is extra long. Specifically so useful in long lesions where there is a distinct difference in the diameter proximally and distally, like in this case. And long lesions consist of about 20% of all PCIs. So if you have an overlapping stent, the overlapping area has got potential hazards. A, you may miss the overlap. B, the overlap may be just a little too much. And that areas are prone for stenosis, restenosis. And if most of the coronaries are tapering, so if you use the same dimensions for the proximal and the distal, there's a good possibility that you will under-expand the proximal or over-expand the distal, both of which has got its own complications. So the long stent system has got its own advantages of much faster, lesser interventional efforts, low complication rates, and instead of 2 stents, you can use 1 at the same cost. So the stent I'm talking about is the Biomime Morph. So I'll just show you the first case, a typical chest pain post-CABG patient. So when you are dealing with SVG, it's always easier to keep it as simple as possible. So this lesion was wired and pre-dilated with balloon, 210 balloon, and then a morph which was actually 3 and 2.5 was deployed. This is a 60 millimeter long stent, and we got excellent flows in the whole lesion. So instead of putting in multiple stents in this otherwise difficult, it's very difficult to approach or to engage and to deploy a stent in a SVG. So this makes life very easy. So the morph is a stent which is a tapering stent which has got larger dimensions which you can choose depending on this thing. The proximal and the distal dimensions come in various combinations and they can be used. So long diffuse lesions can be easier done and more effectively done with a longer stent. So this is my favorite of the lot. This is called a bifurcation stent. You have 15 to 20% of all coronary lesions are bifurcations. You have stent plus PT, T-stent, reverse T, BAW, you can have culotte, you can have any number of combinations with a good procedure going up to 17 to 18 steps before you can complete. So this is a design concept which is to be appreciated because it's got a flexi connector in the mid area, closed cell in the proximal area, and this is the normal open cell design which is in the side branch. So you have to put the stent the deployment of the stent has to be perfect. In that there are 4 markers on the stent. The two markers go into the side branch, 2 markers go into the main branch. That's all what you need to remember. Wire both the lesions, deploy the stent, and if possible do imaging to make sure that you're comfortable. So it's a technically straightforward with high success rate, protects the side branch and allows permanent access. Your number of steps that you require to do the side branch becomes much easier, and it is a drug-eluting stent, sirolimus coated, so it has got all the benefits of drug-eluting stent also. I'll just show you a 58 female. So she had a lesion in the circumflex which was fixed first, and she's got a dual LED system. So both the LEDs have been wired. First I pre-dilate the diagonal looking LED, and after the pre-dilatation the morph is taken, the branch stent is taken. You can see 2 markers inside the diagonal part of it and 2 markers in the main LED, and it is expanded to nominal pressures. You get the stent gets deployed, and post branch deployment, this is the chute. You can see that the main vessel is flowing, so it's a side branch. Then after that, we took an OCT. See, this is very important to see how the OCT looks. This is from the side branch into the LED. You can see that the distal stent has been exactly copied here. There's a normal stent, open cell design. And then you have these long single wire-like projections, which is seen across the opening and into the main vessel, and you have a closed cell design to anchor the whole thing. So this area is not crowded at all, so that when you put a stent into the main vessel, the total stent load gets decreased significantly there. So this is how it looks eventually. This is the distal part, very well done. Good apposition I've got, and This is the wire crossing into the LED from the, I'm again pulled back from the diagonal view part of it. After that, you do a kissing. The biggest advantage here is the recrossing is very easy once you deployed the main stent. And if required, you can do a pot. Otherwise, this can stop at this. So you have number of steps have been significantly reduced, and the results have been excellent, and so far in my experience. So the third product we'd like to, all of you are familiar with, because of the pandemic, we have had youngsters coming with acute myocardial infarction, and the bioresorbable scaffolds are back again. And unlike the previous ones we have, this is a hybrid cell designed with a closed cell at the end of the thing, open cell throughout the stent. It's 100 micron, 24% scaffold to artery ratio, optimal side branch access because it's an open cell design, high radial strength, 22.3, only the metal, few bare metal, cobalt chromium stents got a better radial strength. Low profile, 1.2 millimeter, it's more easily deliverable. Couplets of triaxial RO markers at the end. High vessel conformability, estimated degradation 2 to 3 years. Drug coat of PDLLA plus sirolimus 1.25 micrograms per millimeter squared, and low recoil of 1.23, and low balloon overhang, short abrupt balloon shoulders. Very important. And this got a different size matrix. As compared to the absorb, which is 150 microns, this is only about 100 microns. So this is the radial strength I was talking about. So what is very important is that from the distal end of the scaffold to the tip of the balloon, it is 1.3 millimeters. Why is it important? I will show you in my case. So it can do a tip-to-tip deployment. You just need to overlap the balloon tip with the balloon marker with the distal scaffold marker, and you can get excellent apposition. There is no overlapping of stents, but the struts get together. Is it feasible? Yes, I will show you. So this is an RCA, which is a very long RCA lesion, extremely diffusely diseased, well prepared with IVL and calcified disease. So I got a long way to go. So anyway, distal area was 3.21, MLA was 2.4, and proximal area was 5.9. The RCA was, tightest segment was 2.43, and the total length was about 58.4. So this was dealt initially with, see, what I do is I took a JR in this case, and I put an guide extension catheter, which is used to deploy the distal this thing. Now, I realized through bad experience that a 3 BVS doesn't go through a guide extension catheter. So for the second part of the deployment, I had to change the guide to, confusion. AL, and then deployed the second stent. So you have 2 overlapping stents that has been deployed in this place. And how does it look? I will show you. This is the final run of the PCI OCT run, where it shows that the is very well deployed. You have to just make sure that your BRS is done always and every time with imaging, because there is a very good possibility that you will miss the lesions. So malapposition in the mid segment, that has been post-dilated. After that has been post-dilated, this is just show you the overlapping area. The number of struts in the overlapping area will be slightly more than the regular this thing. But there is no struts overlapping over each other. That is how the thing goes. So post-run RCA shows excellent results. You can see that despite the overlap segment is a little crowded. Otherwise, it's we got excellent areas. So the last device I'd like to talk about is, the video is not working, sorry. It is the closure device which is called Optura. Optura, the advantage is that it is exactly like an angioseal, but you don't have to change the catheters in the middle of the procedure. So it is deployed exactly as an angioseal through the catheter which is existing. That is your, whatever sheath you used, that sheath can be used, and you can deploy the Optura through that. And it gives an equally good results as an angioseal, and the cost is much lesser. 90 days absorption, patient-friendly, sealing absorbed within 90 days. The last was about 3 slides on OCT. Just want to tell you that the calcium detection is automatic, the maximum thickness is automatic, angle is automatic, and since this is there, your life becomes very easy. Just take a OCT run. You don't have to sit at the console and find out what is happening. It tells you straight away. It also identifies the EEL for you. It also gives you the lumen diameter and the EEL to EEL diameters. That helps you to plan your strategy very well. And after the whole thing is over, it gives you a reference lumen diameter, and the areas of under expansion have been marked with the OCT. Thank you.
Thank you, Dr. Mahesh, to enlighten us on Indian innovations. Just for the sake of discussion, you started off with a tapered stent. Now we have stents available which can go safely from 3 to 4.5 millimeter, very new stents. So in that context, is it still a viable option to have a tapering balloon stent?
Yeah, it is good when you have a 3 and a 3.5. When you have a 3 and a 2.25, it becomes an issue. When the difference is significantly massive, then it becomes an issue. Otherwise, you can post-dilate and go ahead, no issues.
So we know biovascular scaffold currently carries a class 3 recommendation, but then we have a device with a DCG approval in our shelf. We have the Indian device. And the data with the MERIS-1 trial, we are also part of that trial. Actually, it was good. Then what's your take on it? You know, what all situations now you prefer or use?
I was using it for very safe lesions till I heard Antonio Colombo. He says if you have the most difficult lesion, the best thing to do is a BRS, because in case something goes wrong, the surgeon will still be able to tackle it. You put a bare metal stent or a metallic stent throughout the LAD, you just kill the opportunity for the surgeon to do anything beyond that. So that really took me by surprise. And calcified lesions, I deep throat the guide or take a guide liner and make sure that the scaffold is not pushed through a very calcified, very rough area. That's all. Take it to the point and deliver it. So far, my results have been, touch wood, very good.
Routinely, as a routine, do you use it now?
So I counsel from above downwards. So when I get a patient, I tell him, these are the options you have. This is the cost system you have. This is most ideal for you. Whatever you choose, we will go by that.
So, hi, hello sir. It was a nice talk. I have a doubt regarding the MERIS 100, the biovascular scaffolds. I understand that once we deploy a certain size, we can only upsize it by maybe 0.25. So suppose you are deploying the stent across a large side branch, and how do you size your biovascular scaffold?
I don't.
You don't.
I don't deploy it across the side branch. I'm very clear. If there is a very significant side branch, I avoid scaffold. I will only go with a normal. So far, no studies to support me to use a bifurcation with the side.
Previous request 1:1 pre-dilatation, and the size cannot be beyond
And imaging.
0.5.
Imaging is mandatory.
Beg your pardon, sir. Sorry to intervene. We're running out of time.
I think we have come to an